All right, so I am back with your second part of your stroke review. Well, I guess it's kind of like the first part. So the first part I recorded and then I don't know what happened to the file. It's not working to anything that I upload it to, so I'm going to have to refilm that one, but this one is going to be basically everything from medications to like a little bit about nursing interventions and rehab. Okay, so for drugs, when it comes to stroke, so the big one that you guys need to know about is TPA. So TPA is alteplase or tissue plasminogen activator, and it's a drug used to reestablish blood flow through blocked arteries, preventing cell death. And so this helps to reestablish blood flow in the brain, give oxygen, nutrients, that sort of thing. The big things with TPA that I have highlighted are you cannot substitute other fibrinolytic agents. It should be administered 3 to 4.5 hours after the onset of signs and symptoms of ischemic stroke. So this cannot be used with hemorrhagic stroke at all. And if you give it above 4.5 hours after symptoms, it can increase your risk for bleeding, other issues. And so TPA is usually delivered via a catheter in the brain. And patients have to be screened before it because that's obviously an invasive procedure. So they're going to do a CT and an MRI to rule out that you had a hemorrhagic stroke, because we can't give it if that's the case. You're going to do a blood test for coagulant disorders to see if you have any increased risk for bleeding, because if that's the case, we're not going to give it. You're going to see if they have any recent GI bleeding, stroke, head trauma within the past 3 months, or major surgery within 14 days. And if that's the case, you can't give it. When you're giving TPA, blood pressure control is super critical for 24 hours after. And you're also going to insert a catheter, NG tube, and multiple IVs because these patients are going to be pretty critical. And like any other drug, you just want to keep an eye on your patient, do vital signs, monitor those neuro checks every 4 hours, that sort of thing. So that is TPA. So there's lots of other preventative drug therapy that can be used. Like I said, nothing can replace TPA, but you can use other things to help. So aspirin is probably the other big drug that you'll see when you go to clinical this term. I feel like I saw aspirin on like every single one of my patients, and it's anywhere from 81 to 325 milligrams a day. Usually 81 is the common dose, but you might use a higher dose after a recent ischemic stroke. So anticoagulants like heparin, those are also used usually after like an emergency, but like long-term use is not as common. Other drugs that you can use for like antiplatelets are going to be your Plavix, your Agrinox, Coumadin, which is your warfarin, Xarelto. I know Dr. Schneider had a huge list of them for us, so I would just be familiar with the names so that way you can understand, like, all right, if I see that drug, I know that it's an anticoagulant and we're trying to prevent a clot from forming to prevent a stroke. Management of hemorrhagic stroke. So like we talked about, you don't want to use TPA. You're also not going to use anticoagulants and platelet inhibitors because those are just going to allow for you to bleed out. So management of hypertension is going to be that main focus. And so you might use oral and IV agents. So think back to your blood pressure drugs, like your beta blockers, your ACE inhibitors, your ARBs. And then you want to keep the systolic blood pressure less than 160. So that's something that I have highlighted. So that's your drug therapy. You also just want to teach your patients about prevention for stroke. So like healthy diet, weight control, smoking cessation. Really that primary prevention is going to be the biggest key when it comes to stroke prevention. There is a little bit of surgical therapy that you can do. The only one that I have really like in my notes is the carotid endarterectomy, CEA. So this is when a plaque is removed and the artery is sewed back up. And so the biggest thing with this is you want to monitor for bleeding. Oh, the other thing I have is you can do stents. And so that attempts to maintain the patency of an artery by keeping it open and allowing blood flow to go through. And so you might do that if somebody can't withstand that CEA, and it's also just less invasive. And so you want to make sure that if this happens that you keep their legs straight, because they usually go in through the femoral artery. So keep your legs straight, do dressing care, and especially like watch for the area distal to the insertion. All right, so now moving into just like nursing interventions. Obviously the goal is we want to preserve life, we want to reduce further brain damage, and we want to reduce disability. So that's just like the overarching goal when it comes to stroke management. And so you're going to think about your ABCs. So you want to monitor your oxygen, artificial airway, intubate if you need to with stroke patients. That might be a common thing because when patients have a stroke, they can become so disoriented that like they just have a hard time keeping their airway open. You want to make sure that they're hydrated, but not too overhydrated. You want to manage their ICP, especially with hemorrhagic strokes because of that just gush of blood. Your primary assessment is going to be cardiac, respiratory, and neuro-based. And once your patient is stable, so once they have the ABCs, you're going to obtain, their health history. So history of the symptoms, history of current illnesses, current meds, risk factors, things like that. You don't want to do that until after you get those ABCs in check. You also want to do your LOC check. Know that with the NIH stroke scale, which is a scale you can do to measure how bad a person's stroke is, the higher the points, the worse it is. Patients might have to go to rehab. There's lots of different specialists like neurologists, PT, OT that they might have to work with. You worry about their movement if they had unsteady gait, provide education, distract the patient, if they're having like an atypical emotional response. You want to help with family member coping, really just educate, help the families, help the patient figure out what they need. I mean, that's about it. So all right, so that is everything that I have for the stroke video. I am going to try to figure out what happened with that first file. I'm probably gonna have to record it so then you guys will get the biggest portion of the review, because obviously this wasn't very much. This was just mainly drugs and then talking a little bit about nursing interventions. But if you guys have any questions, as always, don't be afraid to reach out to me. I'm here for you guys if you need anything. But yeah, so hope you guys have a good weekend.